First, I have to brief you about retropharyngeal space so that you have a better understanding about the patient complaint, examination, the investigation and the treatment. So, let me start with that. See, these are the tonsils. This is a drawn picture and this is a photograph showing the tonsils. So, just behind the tongue, just behind that area of the tonsil, the structure which you see straight, that is the pharynx. Actually, pharynx means it includes a part behind the nose, behind the tongue, as well as lower down. So this pharynx, the structure behind that, which is called as retropharynx. Retro means behind, retropharynx. So I'll show you one side view picture so that you can understand better. See, this is the tongue. Here you will have the tonsil, and this is the pharynx. So this space is called retropharyngeal space. So this actually it's a potential space. Means there is no space as such, but if suppose needed, that part can be expanded. It can suppose you have an abscess, it can occupy that place. That's what it means by potential space. So this space can get infected and it will result in abscess formation. It is usually seen in children. So for medical students especially, for them to understand the retropharyngeal space, it can be a true space which lies between the buccopharyngeal space, fascia and the prevertebral fascia. This one. Sometimes we used to include that, we used to say that the true space lies between buccopharyngeal fascia and the alar fascia. The extent of both are different. The true retropharyngeal space, it starts from the skull base, it goes up to the level of T1 and blends up to T4. The alar fascia starts from the base of skull, it extends beyond T4. That is the difference. Now, this area has got connection with other neck spaces also. So, acute retropharyngeal abscess means abscess in the potential space between buccopharyngeal fascia and the prevertebral fascia, or the true sense between the alar fascia. It's common in children, usually less than 6 years. The contents of retropharyngeal space, they have two structures there, fat and lymph nodes. There are two groups of lymph nodes, medial group and lateral group. This usually disappears after the age group of 6 and 7. So, that's why it is common below the age group of 6. Any infection near the oral cavity or oropharynx, there is a high possibility, depending upon the virulence of the organism, that it can spread to the retropharyngeal lymph nodes, which can turn into an abscess. So what are the sources of the infection? It can be from the adenoids, adenoiditis, or the adenoids being irritated from the sinuses. Usually it's adenoiditis alone. Can be from acute recurrent tonsillitis, can be of dental cause, and in adults, usually it is because of foreign body impaction, or for some reason or the other, instrumentation being done in the hospital and they traumatize the pharyngeal wall, and it can lead to acute retropharyngeal abscess. So the reason, the cause is different in children and adult. Now, coming to the organism, since it is bacterial infection, it usually results from streptococcus or staphylococcus, klebsiella or bacteroids. Sometimes it can be more than one bacteria. It can be a gas-producing bacteria or non-gas-producing bacteria. It depends. The complaints are, to start with, the child will have fever and will have cough and refusal to eat. Because whenever he drinks or eats, he has got throat pain. It becomes so severe that he will not be able to swallow the saliva, and there will be a drooling of saliva too. So at that particular time, he will have change of voice, which we usually in medical terms used to say hot potato voice. And if left untreated, it can proceed to breathing difficulty too. On examination, the patient will be toxic looking, febrile, with tachycardia and tachypnea, open mouth breathing and drooling of saliva, with neck stiffness, slight extension of the head, and he'll be having breathing difficulty also. So on examination of the oropharynx, we can visualize that one side of the posterior pharyngeal wall is bulged and it is congested. So we need to go ahead and do a flexible laryngoscopy. Why? Because we have to know the extent of the retropharyngeal abscess bulge, and we have to see whether the airway, above the airway patency, whether the anesthetist will be able to intubate or not. That's why. And this is a simple procedure which will be done within 5 minutes and no special preparation needed for that. If left untreated like this, the child can develop airway obstruction and the infection can spread from this space to other related spaces, and it can spread down to the mediastinum or to the chest, leading to mediastinitis and even pneumonia, and sometimes septicemia and meningitis too. So I have so many dreaded complications. So that's why I said in the very start, it's a ENT medical emergency. Now we'll come to investigations. The basic investigation, CBC, C-reactive protein will be positive, will be elevated. We'll start with the X-ray neck, and of course the golden standard is we have to do a CT scan neck inclusive of chest, and it has to be contrast too. If suppose we feel that it is the cause is dental cause, then we need to do CBCT also, which means cone beam CT scan of dental. And if suppose chest CT is not done, we need a X-ray chest. And whatever pus we aspirate from that abscess, we have to send it for culture and sensitivity. So these are the investigations. So to start with the X-ray, you have on the left side you have X-ray picture, on the right side the CT scan. You can see there is a bulge, there is a thickening in the area. This thickening usually is very thin. This thickening will be measured at two levels, C2 and C6, and we have a criteria for that. Depending on that, we can diagnose this a case of retropharyngeal abscess. Not only that, along with this, the vertebral spine will be straightened up. Usually it is not. And there may be presence of air shadow, and adults maybe, if the cause is foreign body, the foreign body may be seen. CBCT also to be done. We will start with treatment now. We'll start with oxygen inhalation, and we'll start with IV antibiotics, steroids, analgesics, and IV fluids. And surgery to be done at the earliest. So sometimes anesthetist will have problem with intubation, so we'll take a concern for tracheostomy or cricothyroidotomy, so that we can achieve the airway patency at the earliest. Now, the ENT doctor will be performing the surgery. Suppose there is a dental cause also, we'll call along the maxillofacial surgeon at the same time, so that the single sitting we can deal with both. Suppose there is a periodontitis also, and the pus has drained from there to the retropharyngeal space, we have to take care of that also at the same time. Otherwise, we need two different operations, which is difficult for a child. So I will be speaking only about the drainage of the retropharyngeal abscess. First, to start with, we'll aspirate the abscess, send it for culture sensitivity. Here you have an incision, followed by suction of all the abscess and clearing it up, followed by we will insert a nasogastric tube if necessary. Usually what happens is the child would not have taken anything for past 4-5 days, and he'll be very weak. Just IV fluids alone will not be enough, and soon after surgery also he may be refusing to eat. So it's better to put in a nasogastric tube at least for 2 days. As soon as he starts eating, then we can take it off. That may help. Even if the doctor has missed NG tube, it is no issues. Some of the doctors, they don't wish to have an NG tube. They say start straight off. You can start taking food. That's okay. That's fine. Now, sometimes the abscess could have not in the oropharynx, it could have extended down the neck. So just per oral incision alone will not be enough. Or you may, instead of per oral incision, we may need an external approach. So if we do an external approach, then we'll put in a drain too. So after the surgery, which takes approximately 1 to 1.5 hours, the child will be shifted back to the ICU, where his temperature, respiratory rate, heart rate, and CBC and C-reactive protein will be monitored every day. And it will come down. And we'll change the antibiotic or add up the antibiotic as per the culture sensitivity report also. Usually, by the 3rd or 4th day, all the following set parameters could have become normal. So by the 5th day or maximum 7th or 8th day, the child can be discharged with a complete course of antibiotic and painkiller and vitamins. The red flag. After going home, suppose the child has developed any of these, the child has to be referred back to the hospital at the earliest. These are recurrence of high fever, child starts getting difficulty in swallowing once again, next he develops neck stiffness and cough, or breathing difficulty, or severe headache. In this case, you have to rush back to the hospital to see whether it has recurred or not. And it has to be treated at the earliest. Is there a possibility of all this happening again? There is, but it is not common. So that is how we treat a case of acute retropharyngeal abscess. Thank you.